Hello, I am Professor Sims, and in this video, I will discuss the bone and skeletal system. This is the fourth in a series of 10 lessons held as part of my Anatomy and Physiology 1 course. If you are a student currently enrolled in this course, please consult the syllabus and course Moodle site for assignments, quizzes, due dates, and other course information. In this unit, we will learn about bone, cartilage, and the skeletal system, functions of the skeletal system and each type of bone, how bones are classified, the anatomical features and histology of bone tissue, the steps of intramembranous and endochondral ossification, the processes of modeling and remodeling, how bone is repaired, the effect of exercise on bone, and how nutrients, hormones, and calcium affect bone health. Bone is a sturdy and dense connective tissue constituting the majority of the adult skeleton and providing crucial structural support to the body. In areas requiring movement, such as joints and the rib cage, cartilage offers flexibility and smooth surfaces for muscle attachment. The skeletal system, composed of bones and cartilage, acts like steel beams in a building, maintaining the body's structure and giving it support. Bones aid movement by acting as attachment points for muscles and by transmitting forces during muscle contractions. This interaction between the skeletal and muscular systems is known as the musculoskeletal system. Bones protect internal organs, for example, ribs, shield the lungs, and the heart. On a metabolic level, bone tissue serves as a reservoir for minerals like calcium and phosphorus, and they're the site for fat storage and the production of red blood cells, white blood cells, and platelets. Figure 6.3 illustrates how skull bones encase and shield the brain, and this protects it from external impacts and injury. Their rigid structure absorbs and disperses forces, thereby minimizing damage to the delicate brain tissue inside. The skull's protective barrier is essential for maintaining the structural integrity and function of the brain. Figure 6.4 depicts the head of a femur bone and the bone marrow inside. Yellow bone marrow in the femur functions as a site for fat storage, offering an energy reserve for the body. The red bone marrow in the femur plays a role in the production of red blood cells, white blood cells, and platelets. Although yellow marrow typically predominates in adult long bones like the femur, red marrow may transition to yellow marrow as an individual ages.
The major functions of the skeletal system include support, mineral storage, blood cell production, protection, and leverage. Support. The skeletal system provides structural support for the entire body. Individual bones or groups of bones provide a framework for the attachment of soft tissues and organs. Mineral storage. The calcium salts of bone are a valuable mineral reserve that maintains normal concentrations of calcium and phosphate ions in bodily fluids. Calcium is the most abundant mineral in the human body. A typical human body contains between 1 and 2 kilograms of calcium, with more than 98% of it residing in the bones of the skeleton. Blood cell production. Red blood cells, white blood cells, and platelets are produced in red bone marrow, which fills the internal cavities of many bones. Protection. Delicate tissues and organs are surrounded by skeletal elements. The skull encloses the brain. The vertebrae shield the spinal cord. The ribs protect the heart and lungs. And the pelvis cradles the delicate digestive and inner reproductive organs. Leverage. Many bones of the skeleton function as levers. They change the magnitude and direction of the forces generated by skeletal muscles. The movements produced range from the delicate motion of a fingertip to powerful changes in the position of the entire body.
The adult skeleton includes 206 bones, categorized based on their shapes. The shapes of bones determine their functions, and each category serves a distinct purpose in this way. Long bones, such as the humerus and femur, exhibit a cylindrical shape that is longer than it is wide. These bones are relatively long and slender, and they're found in the arms, legs, palms, soles, fingers, and toes. They act as levers facilitating movement through muscle contractions. Short bones are small and boxy. They're found in the wrists and the ankles. They have cube-like shapes with approximately equal dimensions in length, width, and thickness. This functions to provide stability, support, and limited motion in the short bones, and the short bones contribute to overall structural integrity. Flat bones, despite their misleading name, are actually often curved. They possess thin, roughly parallel surfaces, forming the roof of the skull, the sternum, ribs, and scapulae. These bones provide protection and serve as muscle attachment sites. Irregular bones exhibit more complex forms with short, flat, notched, or ridged surfaces that fulfill diverse functions. Examples include the spinal vertebrae, bones of the pelvis, and facial bones. Sutural bones are small, flat, irregularly shaped bones found between the flat bones of the skull. There are variations in the number, shape, and position of sutural bones. Their borders resemble a jigsaw puzzle, like pieces of a jigsaw puzzle that are fitting together. They range in size from a grain of sand to about the size of a quarter. Sesamoid bones are generally flat, small, and shaped like sesame seeds. They develop within tendons where joints generate significant pressure, commonly found in the feet, hands, and knees. These bones vary in number and placement. Figure 6.6 and Table 6.1 provide a summary of bone classifications. Bones, again, are categorized based on their shape and structure, and they're grouped in such categories as flat, long, short, irregular, sutural, and sesamoid. Each type of bone serves distinct functions, either providing support, protection, or facilitating movement within the body.
Let's talk about bone shape, because that can be used to classify bones. Long bones. It's not that they have to be long per se. It's more about their cylinder shape and the fact that they're longer than they are wide. These bones tend to be moved in muscle contraction. The femur in the leg is a great example of a long bone. The tibia and fibula in the legs are also long bones. In the arms, you can have the humerus, ulna, and radius. In part of the hands, you have metacarpals and phalanges. In part of the feet, you have metatarsals and phalanges. Short bones. Unlike long bones, these are more like a cube, as their length and width are close to equal. These bones are also moved using muscle contraction, and these bones can offer stability. Carpals in the wrist and tarsals of the ankle are examples. Sesamoid bones. Like a sesame seed, they are roundish. They're great about handling pressure. The patella is an example. Flat bones. So unfortunately, you don't want to just go on the name because they aren't necessarily flat. They're often curved and thin. Skull bones, otherwise known as cranial bones, and shoulder bones, otherwise known as scapulae, are examples. And irregular bones, a shape that is irregular. Basically, there isn't a specific shape description you can use to define them. Irregular bones can be protective from an assortment of forces. Vertebrae are a great example. Let's talk a bit about what's going on inside bones. There are two general types of bone tissue: compact bone tissue, an outer layer that is hard, and then spongy bone tissue, a layer where you will find bone marrow. Some of it is yellow marrow, and it stores fat, which is important for long-term energy storage. And then red marrow, that's where blood cells can be made. Red blood cells, which transport gases, and white blood cells, which are important for defending the body. Red marrow also involves platelet production. Platelets aren't really cells, but cellular fragments that are critical in allowing blood to clot. So overall, it makes sense that we say bones are vascular because they have a rich blood supply. Interesting fact, in emergencies, there is even a way to administer fluids and medications into the bone in a similar way that they can be delivered by an IV. Let's talk about cells involved with bone or cartilage. First, osteoblast. These are cells that make bone. They can mature into another type of cell called osteocytes. These cells maintain bone structure and make up the majority of bone cells present. Osteoclast. These cells actually break down bone structure, and the way they do it is cool. Remember the organelles called lysosomes? Well, osteoclasts have a lot of lysosomes. In lysosomes, there are enzymes there, and together with acids, they can help dissolve bone. You might wonder, why would you want to normally break down bone? Well, the body is always responding to stresses, and some part of old bone is removed, and then some parts are rebuilt in what is called bone remodeling. So osteoclasts are needed for this normal process. It's estimated that every year, approximately 5 to 10% of the skeleton is remodeled. So remodeling in the skeletal system means bone that has been damaged or is just old is reabsorbed and replaced. If you get injured or if you do a lot of exercise, this can also impact remodeling. In addition, the process of breaking down bone also releases minerals that the body may require. A major mineral bone store is calcium. Specific hormones from the endocrine system actually can signal whether calcium in the bones may need to be released. Specific hormones also signal when calcium is deposited. Bone cells work alongside other cells. For example, chondroblasts. Chondroblasts make the connective tissue cartilage. Chondroblasts can mature into chondrocytes, which maintain this cartilage. They make up the cartilage. Cartilage supports bone. It's important in joints where bones are connected. It's also a template for bone placement. In fetal development, it is the cartilage made by chondroblast that is meant to serve as the matrix for the bones. Eventually, bone will replace most, but not all, of the cartilage matrix.
Let's go into the gross anatomy of bones. First, we'll talk about long bones. Long bones consist of two parts, the diaphysis and the epiphysis. The diaphysis, a tubular shaft between the proximal and distal ends, encloses the medullary cavity containing yellow marrow, supporting structural integrity with dense, compact bone. The epiphysis, a wider section at each end filled with spongy bone, connects to the diaphysis via metaphysis, housing the epiphyseal plate during growth, which transforms into an epiphyseal line in early adulthood. Within the diaphysis, the medullary cavity holds bone marrow, transitioning from red to yellow with age, each serving different hematopoietic functions. The endosperm, lining the medullary cavity, facilitates bone growth, repair, and remodeling, while the outer periosteum, a fibrous membrane, contains blood vessels, nerves, and lymphatic vessels. Tendons and ligaments attach to bones at the periosteum, except at joint-forming epiphyses, where articular cartilage reduces friction. The nutrient foramen aids bone growth by allowing blood vessel access into the shaft, sustaining bone health with accompanying arteries and veins. Flat bones, like those in the cranium, incorporate spongy bone between layers of compact bone, providing enhanced protection for the internal organs. Figures 6.7 and 6.8 show the gross anatomy of a typical long bone. The diaphysis provides structural support and serves as a site for muscle attachment. At each end of the diaphysis are the epiphyses, which contribute to joint formation and are covered with articular cartilage for smooth movement. Within the diaphysis lies the medullary cavity, containing yellow bone marrow that is surrounded by compact bone, while the spongy bone and red bone marrow are found in the epiphyses. Figure 6.9 gives an illustration of the gross anatomy of a typical flat bone. The central spongy bone is comprised of delicate trabeculae arranged in a network-like pattern. These trabeculae create spaces within the bone, allowing for storage of red bone marrow, which is crucial for the process of blood cell formation. Surrounding the spongy bone on both sides is a layer of compact bone that is dense and hard, and it serves as a sturdy barrier, safeguarding the delicate inner components of the bone from external forces and impacts. The surface features of bones or bone markings vary by location and function and include articulations, projections, and holes. Articulations mark points where bone surfaces meet, such as a head, which is a widened proximal end supported by a narrow neck, and facets and condyles, which are smooth and rounded articular surfaces. The ramus contributes to joint structure. Projections serve as attachment points for tendons and ligaments. Tuberosities are large, rough projections, while crests are prominent, narrow ridges. Trochanters are large, irregular projections. Lines are narrow ridges. Tubercles are small, rounded projections. Epicondyles are raised areas above condyles. And spines are sharp, slender processes. Depressions and openings within bones facilitate the passage of blood vessels and nerves. Fossae are shallow depressions. Fissures are narrow openings. Foramina are openings for vessels and nerves. Canals or meatuses are larger passageways. Sulci or grooves are furrows. And sinuses are air-filled chambers aiding in functions like resonance. Figure 6.10 gives examples of these bone markings. Tuberosities, crests, and foramina accommodate specific functions like providing leverage for muscle attachment or allowing passage for blood vessels and nerves. The arrangement and prominence of these features reflect the bone's functional demands and anatomical relationships within the body. An osteon consists of bone cells organized around a central canal and separated by concentric lamellae. This central canal, also known as the Haversian canal, runs parallel to the bone's axis and harbors essential structures like arteries, veins, lymph vessels, and nerves. Perforating canals extend perpendicularly to the bone's axis, linking the central canals of adjacent osteons. Lamellae, nested concentric rings of matrix, encircle the central canal, providing structural support. Circumferential lamellae, specialized structures found at the outer and inner bone surfaces, contribute to bone growth and maintenance. Interstitial lamellae fill spaces between adjacent osteons formed by recycled matrix components. Osteocytes, which are mature bone cells, reside within lacunae, unable to divide, with each lacuna containing a single osteocyte. Processes of osteocytes extend into narrow crevices called canaliculi, connecting lacunae to the central canal, facilitating nutrient exchange and cellular communication within the bone tissue. There are four main types of bone cells: osteoblasts, osteocytes, osteogenic cells, and osteoclasts. Osteocytes maintain mineral concentrations and communicate through canaliculi. Osteogenic cells with high mitotic activity differentiate into osteoblasts, ensuring the replenishment of bone cells. Osteoclasts are responsible for bone reabsorption. They break down old bone and maintain a dynamic equilibrium with osteoblasts by facilitating constant bone reshaping. Figure 6.11 shows the four types of bone cells. Osteogenic cells are undifferentiated and develop into osteoblasts. When osteoblasts get trapped within the calcified matrix, their structure and function change, and they become osteocytes. Osteoclasts develop from monocytes and macrophages, and they differ in appearance from other bone cells. Compact bone provides support to the long bones, diaphyses, and is organized into osteons. Each osteon comprises concentric lamellae surrounding a central canal, which houses blood vessels and nerves. Spongy bone accommodates osteocytes in the lacunae, contributing to bone strength and lightness. Spaces within some spongy bones house red marrow for the production of blood cells. Arteries passing through compact bone nourish the spongy bone and medullary cavity. Nutrient foramina, small openings in the vessels in the periosteum and marrow cavities, along with nerves, contribute to bone nourishment, pain sensation, and regulatory roles, especially in metabolically active bone regions. Figure 6.12 is a diagram of compact bone. This cross-sectional view of compact bone shows the basic structural unit, the osteon. You can see the concentric lamellae and the central canals. Figure 6.13 is a diagram of spongy bone. Spongy bone is composed of trabeculae that contain the osteocytes, and red marrow fills the spaces in some of these spongy bones. You can see here in figure 6.15, the nutrient foramen facilitate bone nourishment and innervation. The blood vessels and nerves transverse through the nutrient canal, distributing essential nutrients and sensory information throughout the bone tissue. The presence of the nutrient foramen is important for maintaining bone health and functionality by ensuring adequate blood supply and neural communication. In the early stages of embryonic development, the skeletal framework of the embryo comprises fibrous membranes and hyaline cartilage. The onset of bone development, known as ossification or osteogenesis, typically commences by the 6th or 7th week of embryonic life. During skeletal development, cartilage serves as a template for bone, acting as a replacement tissue. The cartilaginous matrix produced by chondroblasts and containing hyaluronic acid, chondroitin sulfate, collagen fibers, and water, provides a flexible and semi-solid foundation for determining bone locations. Although damaged cartilage lacks efficient self-repair mechanisms due to its avascular nature, the bone gradually forms on this cartilaginous matrix throughout fetal development and childhood, with some cartilage persisting into the adult skeleton. Two primary pathways govern bone formation: intramembranous ossification and endochondral ossification. Regardless of the pathway, bone tissue remains the same. In intramembranous ossification, both compact and spongy bone directly originate from mesenchymal connective tissue sheets. This process is responsible for forming flat facial bones, most cranial bones, and the clavicles. Mesenchymal cells within the cranial bones, the embryonic skeleton, differentiate into osteoblasts, creating ossification centers where bone tissue solidifies. Endochondral ossification involves the replacement of hyaline cartilage with bone. The diaphysis and long bones bases, including those at the skull's base, form through endochondral ossification. This process begins with mesenchymal cells differentiating into chondrocytes, forming the cartilaginous skeleton precursors. In the cartilage, as the cartilage calcifies, blood vessels penetrate, initiating the transformation of the perichondrium into the periosteum. Osteoblasts form a compact bone collar around the cartilage in the diaphysis. Primary and secondary ossification centers contribute to bone development, with the epiphyseal plate facilitating longitudinal growth until adulthood. Intramembranous ossification progresses through 4 stages. Mesenchymal cells cluster to form ossification centers, where osteoid is secreted to entrap osteoblasts, transforming into osteocytes. Subsequently, the trabecular matrix and periosteum develop, followed by the formation of compact bone over trabecular bone and the condensation of blood vessels into red marrow. Endochondral ossification progresses through 5 stages. Mesenchymal cells differentiate into chondrocytes, forming the cartilage model in the perichondrium. Capillaries penetrate the cartilage, leading to the transformation of the perichondrium into the periosteum and the development of a periosteal collar. Primary ossification centers form, followed by continued growth of cartilage and chondrocytes, while secondary ossification centers develop. Cartilage persists at the epiphyseal plate and joint surfaces as articular cartilage. Bone growth mechanisms involve the epiphyseal plate for longitudinal growth and appositional growth for increased diameter. Longitudinal growth is facilitated by hyaline cartilage cells forming tall columns at the epiphyseal plate and within the articular cartilage. The rapid division of cells at the top of these stacks thickens the epiphyseal plates, leading to the lengthening of the entire long bone. As chondrocytes closer to the shaft enlarge and die, the surrounding cartilage matrix deteriorates, leaving behind calcified cartilage spicules. Osteoblasts in the medullary cavity then ossify these spicules, forming spongy bone. Eventually, the hyaline cartilage at the epiphyseal plate is entirely replaced by bone, transforming the plate into the epiphyseal line, typically occurring in early adulthood, signaling the end of height growth. In contrast, appositional growth involves osteoprogenitor cells beneath the periosteum differentiating into osteoblasts, forming new osteons on the external bone surface. Simultaneously, osteoclasts remove and recycle lamellae at the inner surface, leading to the gradual enlargement of the medullary cavity as the bone diameter increases. Although appositional growth is crucial for expanding the diameter of the existing bones, it does not contribute to the formation of the original bone structure. The epiphyseal plate functions as the primary site for longitudinal bone growth and growing bones. As bone maturation occurs, the epiphyseal plate transforms into the epiphyseal line, marking the cessation of longitudinal growth. Epiphyseal plates are observable in developing bones, where epiphyseal lines represent the remnants of these plates in mature bones.
Bone consists of a dense, compact layer and a spongy, cancellous structure. While compact bone forms an organized outer shell, cancellous bone consists of thin, interlocking plates called trabeculae. Osteoblasts and osteoclasts are the osteocytes, or bone cells, that make up bone tissue. Bone continually renews its structure and strength through remodeling. Osteoclasts break down existing bone, and osteoblasts build up new bone. In normal bone, adequate physical stress and changing blood calcium levels prompt osteocytes to initiate bone remodeling. Osteoblasts emit a cytokine that transforms immature osteoclasts into mature osteoclasts. In a process called resorption, mature osteoclasts use enzymes to remove existing bone tissue. Then, osteoclasts release chemicals that stimulate immature osteoblasts to mature and release osteoprotegerin, a protein that deactivates osteoclasts, stopping bone resorption. In response, bone formation occurs. Mature osteoblasts deposit osteoid, a matrix that contains minerals such as calcium and phosphorus, and a strong, flexible protein called collagen. Calcium and phosphorus crystallize or mineralize the osteoid, then transform into sturdy hydroxyapatite crystals, completing the bone formation process. In both men and women, before midlife, bone resorption and bone formation are balanced. Hormones and other factors influence bone remodeling. For example, estrogen hormone suppresses osteoclasts, inhibiting resorption to help maintain bone strength. After midlife, estrogen levels fall and osteoclast activity may go unchecked. Increased resorption can lead to bone loss. Osteoporosis is a progressive disease in which the rate of bone resorption exceeds bone formation. As a result, the trabeculae in cancellous bone become fewer and farther apart. The compact bone thins, and overall, the bone becomes weak, fragile, and prone to fractures. Treatments for osteoporosis include calcium and vitamin D supplements to help maintain blood calcium levels, anti-resorptive medications that promote bone strength by preventing osteoclast activation and excessive resorption, anabolic medications which increase osteoblast activity and promote bone formation, and exercise, including weight-bearing activities which add stress to bone, promoting remodeling.
A broken bone is called a fracture. Fractures vary in severity, with potential complications, such as fat globules released into the bloodstream from a fractured femur, posing risk like respiratory distress and, if untreated, potential fatality. Fractures are categorized based on complexity, location, and other characteristics. A simple or closed fracture involves a clean break of the bone without penetrating the skin, while a compound or open fracture occurs when the bone protrudes through the skin. Transverse fractures break perpendicular to the bone's long axis, whereas linear fractures occur parallel to the long axis. In oblique fractures, the break happens at an angle, neither perpendicular nor parallel to the bone. Spiral fractures are the result of excessive twisting of the bone, while green stick fractures involve bending without complete breakage. Compression fractures occur when the bone is crushed due to the upward or downward force applied to it. Potts fractures affect both bones of the arm or the leg, and comminuted fractures entail the bone breaking into multiple fragments or pieces. Figure 6.20 shows some examples of the different types of bone fractures. These include closed, open, transverse, spiral, comminuted, impacted, green stick, and oblique fractures.
A fracture can be open or closed. These can also be called compound or simple fractures, respectively. An open fracture is one in which the bone breaks through the skin, or a deep wound exposes the bone. Meanwhile, a closed fracture does not break the skin. It must be noted that, by definition, an open fracture is infected. Therefore, it is important to get medical care immediately. The wound needs to be surgically cleaned by a medical professional, which involves debridement, the removal of all foreign contaminants and diseased tissue. Then, the bone is stabilized using implanted rods and screws, and the wound is closed with stitches. A closed fracture can still damage surrounding soft tissue, and this results in fracture blisters. These can form within 2 days if the injury is left untreated. Typically, the injured area is immobilized with a cast. Fractures can also be partial or complete, which is exactly what it sounds like. A partial fracture is an incomplete break, while a complete fracture means the bone is separated into 2 or more pieces. Partial fractures are less serious, and typically you will just need a splint or cast. Complete fractures can be further classified according to the position of the breakage as transverse, oblique, longitudinal, or comminuted. A transverse fracture is one in which the break is straight across the bone perpendicular to its long axis. An oblique fracture is one where the break is diagonal. A longitudinal fracture is one where the break is along the bone's long axis. A comminuted fracture is one in which the bone breaks into more than two pieces and typically occurs due to a severe accident. Fractures can also be stable or displaced. With a stable fracture, also called a non-displaced fracture, the bone's broken ends line up. They have not shifted out of place. However, with a displaced fracture, there is a gap between the bone's broken ends, and repair may require surgery. Typically, bone fractures result from strong forces, such as from a fall. Sometimes they can result from repeated stress. Stress fractures occur when tiny breaks form from repeated stress on a specific bone. These fractures are hard to spot on an X-ray. They are more common in athletes due to constant training. Some fractures can also result from medical conditions that weaken bones, which include osteoporosis, some cancers, or brittle bone diseases. Fractures which occur as a result of medical conditions are known as pathological fractures. The older we get, the less force our bones can withstand. For women, calcium regulation becomes more difficult after menopause, since there is a drop in estrogen, which regulates a woman's calcium. Osteoporosis results in an increased risk of fractures, with the most common being compression fractures. Compression fractures occur in the spinal column, resulting in vertebrae collapsing. Children's bones are different from adult bones. For one, they have growth plates, which are made of cartilage and allow bones to lengthen until the individual reaches their full height, at which point the cartilage is replaced by bone. Fracture of a bone plate can cause the bone to stop growing or to grow crookedly. Children's bones are also more elastic, so fractures tend to be different. A green stick fracture occurs almost exclusively in children. This occurs because children's bones are soft and flexible, and able to bend more than adult bone, so they can break on just one side of the bone. Children are also more likely to get torus, or buckle fractures, in which the bone buckles rather than breaks. There are other types of bone fractures. For example, spiral or torsion fractures occur when a bone is twisted apart, and avulsion fractures occur when a fragment of bone is separated from the main mass. Depending on the location of the fracture and its severity, symptoms of a fracture may include pain, bruising, swelling, and bleeding. In addition, the individual may be unable to put weight on the injury or move the affected area. There may also be angulation, in which the affected area is bent at an abnormal angle. If a large bone, such as the pelvis or femur, is fractured, the individual may be dizzy, pale, and nauseous. Complications of a bone fracture can include malunion. This is when the fracture heals in the wrong position. In the case of an open fracture, an individual can develop chronic osteomyelitis, which is a persistent infection of the bone or bone marrow. Another potential complication is avascular necrosis, or bone death. This occurs when a bone loses its blood supply and dies. In the case of children, a fracture affecting a growth plate can result in a deformity.
The natural healing process of a fractured bone occurs regardless of whether a physician aligns it back into its anatomical position. Failure to correctly reset the bone may result in its continued deformity during the healing process. When a broken bone is manipulated and returned to its natural position without surgery, the procedure is called closed reduction. In contrast, open reduction involves surgical intervention to expose the fracture and realign the bone. When the bone breaks, blood flows from vessels torn by the fracture. Blood clotting begins approximately 6 to 8 hours after the fracture, forming a hematoma. Disruption of blood flow to the bone results in the death of bone cells around the fracture. Within about 48 hours, chondrocytes form the endosteum, create an internal callus by secreting fibrocartilaginous matrix between the two ends of the broken bone. Simultaneously, periosteal chondrocytes and osteoblasts create an external callus of hyaline cartilage and bone around the outside of the break, stabilizing the fracture. Over the next several weeks, osteoclasts reabsorb the dead bone, while osteogenic cells become active, divide and differentiate into osteoblasts. The cartilage in the callus is replaced by trabecular bone via endochondral ossification. Eventually, the internal and external calli unite, and compact bone replaces spongy bone at the outer margins of the fracture, completing the healing process. A slight swelling may persist on the outer surface of the bone, but often this region undergoes remodeling. No external evidence of the fracture typically remains after remodeling is complete. Figure 621 shows the stages of fracture repair. When the bone breaks, a hematoma is formed. Next, the fibroblasts and chondrocytes infiltrate the hematoma, producing collagen fibers and fibrocartilaginous matrix. This matrix connects to the broken bone ends, forming a fibrocartilaginous callus. Blood vessels and new capillaries, fibroblasts, and macrophages then invade the site. Next, the fibrocartilaginous callus is replaced by a hard callus of woven bone as osteoclasts deposit new bone matrix, bridging the gap between bone fragments and strengthening the site. During the long process of bone remodeling, osteoclasts reabsorb excess bone tissue, and osteoblasts deposit new bone tissue to restore the bone's original shape and strength. Eventually, the fracture site blends seamlessly with the surrounding bone. The skeletal system is greatly influenced by various factors, such as dietary intake, hormonal secretions, and muscular activities. Regular exercise, particularly resistance training, promotes thicker bones by stimulating bone deposition in response to mechanical stress. Nutrition also plays a crucial role in bone health, with nutrients like calcium, vitamin D, vitamin K, magnesium fluoride, and omega-3 fatty acids contributing to skeletal well-being. These nutrients collectively support bone mineralization, density, and inflammation reduction. The endocrine system contributes significantly to bone health through the secretion of hormones that influence bone growth, maintenance, and remodeling. Growth hormone, thyroxine, sex hormones, and calcitriol are pivotal in regulating osteoblast activity and bone matrix synthesis. Table 6.6 shows several hormones and their roles in maintaining bone tissue health. Aging poses challenges to bone health, often manifesting as osteoporosis, a condition characterized by decreased bone mass. This is particularly relevant in postmenopausal women due to reduced estrogen production. Osteoporosis can lead to severe consequences, such as increased vulnerability to fractures, especially in critical areas like the hip. Prevention strategies encompassing proper nutrition, weight-bearing exercises, and early interventions are important for maximizing bone mass before the age of 30 and minimizing the risk of osteoporosis. Additionally, hormones like parathyroid hormone and calcitonin influence osteoclasts, playing roles in bone resorption and calcium homeostasis, which is the delicate balance maintained by these hormones, ensures the continuous modeling and remodeling of bone tissue throughout life. Calcium, an essential mineral, holds prominence not only as the most abundant mineral in bones, but also as the most prevalent in the entire human body. Beyond its role in bone mineralization, calcium ions contribute significantly to various physiological functions, including dental health, heart rate regulation, muscle contraction, blood coagulation, and nerve impulse conduction. Maintaining a normal blood calcium level, approximately 10 milligrams per deciliter, is critical for overall health. Deviations from this balance result in hypo or hypercalcemia. Hypocalcemia, characterized by insufficient calcium levels, adversely affects multiple body systems, influencing circulation, muscles, nerves, and bone. Insufficient calcium can impede blood coagulation, disrupt heart rhythms, and hinder muscle contraction. It can even compromise nerve function and render bones quite brittle and more prone to breakage. Causes of hypocalcemia range from hormonal imbalance to dietary inadequacy, with varied treatment approaches depending on the underlying factor. Conversely, hypercalcemia, marked by elevated calcium levels, induces an underactive nervous system, leading to symptoms such as lethargy, sluggish reflexes, constipation, loss of appetite, confusion, and in severe cases, coma. Maintaining calcium homeostasis involves complex interactions among the skeletal, endocrine, digestive systems, and the kidneys. Dietary intake provides calcium stored and released by bones to regulate blood levels. Parathyroid hormone responds to low calcium by stimulating bone reabsorption, kidney reabsorption, and vitamin D synthesis, raising blood calcium. High calcium triggers calcitonin release, inhibiting bone reabsorption, enhancing bone uptake, and decreasing renal absorption, lowering blood calcium. This intricate feedback loop ensures optimal blood calcium levels, which are vital for physiological well-being.
Calcium is the most abundant mineral in the body, and because it's the most abundant mineral, it has extreme significance. In fact, we need calcium for things such as bone formation, blood clotting, muscle contractions, and nerve conduction. And because we have such a great need for calcium, our body utilizes a feedback loop to help us fend off periods when blood calcium may be too high, and we call that hypercalcemia, and when blood calcium levels may be too low, and we call that hypocalcemia. So in our first example, let's imagine that we have someone who hasn't been supplementing their diet with sufficient amounts of calcium. It would be plausible for them to be in a state of hypocalcemia, which again means low amounts of calcium. So in this example, the decrease in calcium is the variable. Now, this decrease in calcium is going to be sensed by a sensor, and the sensor in this example would be the kidneys, as they monitor calcium levels within the blood. So the kidneys would then relay this message to a control center, which is the brain. And the brain would task the parathyroid gland, noted by the green structures you see here, to secrete parathyroid hormone. Parathyroid hormone would then lead to the action of an effector. And in this case, the effector would be increased osteoclast activity. So remember that the role of osteoclasts are to clean up old bone or reabsorb bone tissue. And so what the osteoclast will do is reabsorb bone tissue. And by doing this, reabsorbing the bone tissue, which contains calcium, this calcium can then be deposited into the blood and as a result, increase blood calcium levels, which ultimately reverses the initial hypocalcemia that we noted earlier. Now, let's imagine in another example that we have someone who has been over-consuming or over-supplementing their diet with large amounts of calcium. It would be plausible for them to be in a state of hypercalcemia, which again means high amounts of calcium. So in this example, the increased amounts of calcium represent the variable. Now, this increase in calcium is going to be sensed by a sensor, and the sensor in this example will still be the kidneys, as they monitor calcium levels within the blood. So the kidneys would then relay this message to a control center, which is still the brain. And the brain would task the thyroid gland, shown by the entire gland here except the green areas, to secrete the hormone calcitonin. And calcitonin would then lead to the action of an effector. And in this example, the effector would be a decrease in osteoclast activity, because the role of calcitonin is to specifically inhibit osteoclast activity. So in essence, what we're saying is that the body is halting the uptake of calcium from the bones to prevent there from being even higher amounts of calcium in the blood. And so as a result, the body doesn't continue increasing calcium levels, thereby counteracting the initial high levels of calcium.
Thank you guys for watching. Don't forget to do the reading, check the description for more videos related to these topics, and leave your questions for me in the comments below.